Hello people, welcome to Estonia and Tallinn's e-health conference.
Hello to everybody and welcome to Tallinn, as Mario said.
My name is Marjo Näkki. I'm a journalist from Finland who's been living in Estonia for years and calls this tiny city, beautiful city, her hometown. I'm working at the moment in Moscow as a correspondent for the Finnish broadcasting company, but I'm always so excited to be back home.
And I'm Neeme Raud. I'm another moderator who will be guiding you through these 3 days here in Tallinn at this conference. I was a news anchor at the Estonian National TV, and I was a correspondent in New York and Moscow before. And now, e-health. Estonia is really proud to have this conference because during our presidency in European Union, the e-services IT sector is our focus. And in Estonia, we have experience to share with you in that field, and we hope the conference will be very interactive. You have always chance to ask questions from our speakers and also gaining new knowledge on the new world of IT, where I think we all feel like little children. But let's get started with a little video.
Welcome to the conference. Before kicking things off, we would like to take a few moments to go over some important safety instructions. To ensure your safety and well-being, the conference area is secured by the Estonian police. In the case of an emergency situation, we kindly ask you to follow their safety instructions. In the case of an emergency, we will sound an alarm. The alarm will ring continuously for over a minute or will be activated twice within 5 minutes. After the alarm, we will initiate the evacuation of the building and you will be required to proceed to your nearest exit. Please take note of the green lit emergency exit signs around you. There are 4 marked exits in the black box. 2 are located along the back wall and a further 2 on the left and right. There are 13 emergency exits out of the building, 11 of which are located on the first floor. Once you have exited the building, head directly to the designated assembly point, which is located behind the building, on the pedestrian walkway near the parking lot. In the case of an emergency, we would ask that you remain at the assembly point until every person has been accounted for and you have been cleared to leave by the rescue workers. And with these simple and easy steps, we conclude our safety announcement. Thank you for your attention, and we wish you a safe and pleasant conference.
The future is already here. Our children are the users of the digital services we create today.
Último aviso a los señores pasajeros del vuelo Air France.
digital single market. Using my personal data abroad gives me faster access to the digital services I really need.
Well, we started as a little Nordic Estonian humor and a reminder that we are all safe here. And it's time to move on to our discussions. But first of all, Mario, I have to show you something. I have in my pocket Estonian ID card, and this is really the center of my life. I have to confess I was in hospital a month ago, and the only document I needed to see a doctor, to pay my bills, to get my prescriptions was this ID card. So in this video, the ID card was the solution to a problem to get a carrot. We can say in Estonia, this little card does almost everything. I can pay taxes and whatsoever with this card, with the help with this card, and of course the e-health is on this card. What about Finland?
Oh, what a show-off. Well, actually, in Finland, we do have a digital prescription as well. But the problem is, I think, at least for myself, that if I go and see my Finnish doctor in Finland, and then I get the digital prescription, I come home to Tallinn, and I cannot use that same prescription in the Estonian pharmacists.
Well, in this conference, we'll be discussing how to make all those services, health services, available throughout the European Union. And I have good news for you.
Really?
Since May next year, Estonia and Finland have a policy that you can use. You can fill your prescriptions here in Tallinn.
Wow, that's great news. Wouldn't we all like that?
Great. So, okay, enough to be children. Let's jump to the conference. And before we go to speakers, we have some more information to share with you. Some practical information.
Mm-hmm. So these sessions in the upcoming seminar will take place in 3 different rooms. So this, where we are here today, is called Engine Room. And you can find yourself under the poster. It says Engine Hall, so then you know where you are. The other 2 halls are situated downstairs. They are called Power Station and Steam Room. And fear not, Steam Room is not sauna, even though we are in Estonia.
Okay, all the breaks are downstairs, the main hall. There you find the buffet, there you find food, lunch, there is exhibition, and there is the receptions. There are the receptions, and all the toilets are also located on that floor. So everything on the main floor, to know.
And because this is e-health conference and we are in e-Estonia, we need to be paper-free because we are so upfront and we love to be paper-free. And of course, you need to be on your Facebook and on Twitter, just updating your statuses of being here in Tallinn. And then you have, and this is why you have free the data, Wi-Fi, it's called free the data, and password is Fifth Freedom, which is reference to one of the Estonia's presidency goals to get the free flow of data all over Europe.
And another important address is delegate.eu 2017.de. That's the page where you can provide us your valuable feedback on the conference. And the Twitter.
Yes, tweets. So, hashtag is eHealthTallinn, and you can find our partners and hashtags and all the information in Twitter. Please use the hashtag eHealthTallinn.
So that was the long introduction to our conference. Now, it's my pleasure, our pleasure, to welcome to the stage Estonian Minister of Health and Labour, Mr. Jevgeni Ossinovski, to start the conference and to share some Estonian experience on that field. Please.
Thank you very much. Now it's time for another long introduction before we get to the real discussions. First of all, ladies and gentlemen, let me welcome you here in Tallinn. It's an honor and a great pleasure to have you here in such great numbers, first of all, but more importantly, people from very different professions and people with different expertise all present here for this very important topic. So on behalf of the Ministry of Social Affairs, Government of Estonia, the EU Presidency, welcome Digital has become a part of our everyday lives, of course, and digital revolution transforms our economies and societies across all sectors and domains. Digital innovation in health sector is therefore embedded in the overall context of a digital society and cannot be dealt with in isolation from other fields of e-governance, and that's one of the core sort of understandings of Estonia here, that we have been able to progress in e-health primarily because we have been able to move towards a digital society at large. Estonia is a small country, as you very well know, with a population of 1.3 million people. When we regained our independence 26 years ago, it was clear that the only way for our small public administration to be able to provide good quality public services is to do things differently, in a smarter and more sustainable way. And that's when we started building up our e-government. Back then we were in a relatively lucky position to be able to do it from scratch without having this baggage of all kinds of old-time solutions being dragged behind us. It all started with setting up the nationwide secure data exchange layer called the X-Road, open to both public and private organizations. And since 2001, every Estonian has a digital identity, a mandatory ID card for secure authentication and authorization. That was demonstrated by Neeme a couple of minutes ago. And these, of course, are backbones of our digital society and provide a solid foundation for development of e-health solutions. We are, of course, proud about what we have achieved so far, but it doesn't mean that we're complacent about it. We want to develop our public and private e-services further, to make it even easier for people to communicate with the government and to make public and private services better and more accessible. But Estonia, as any other country in Europe, is too small to take full advantage of the opportunities offered by digital innovation. This is why we have put Digital Europe and free movement of data high on the political agenda of the European Union Council presidency during these 6 months. So it's an overarching priority for the presidency across all sectors, and that, of course, in healthcare means e-health. At the Digital Summit in Tallinn less than a month ago, European leaders reaffirmed their desire and commitment to move Digital Europe forward. The heads of states and governments discussed how to create much needed trust and security and envisaged the infrastructure, markets and labor needs to create a digitally resilient and competitive Europe. So, which is a good development, that we are moving from arguments why not to do things to actually discussing what has to be solved in order to move forward with wider digital innovation. The free movement of data is something that concerns all European policies and fundamental freedoms, of course, and we need to find ways to use data in a secure manner for our individual and collective benefits. And here, although Estonia has been able to accomplish that nationally, how to scale it on a European level clearly remains a challenge. The future of Europe is digital, and the future of healthcare is, of course, personalized, and that cannot be achieved without digital. It's not about technology as such, but it's more about how we are putting technology to work to make our healthcare services better and more efficient, to aid our health professionals in their clinical decisions, to renew processes, to adopt new models of care with more emphasis on prevention, personalized and integrated care. Innovation in healthcare through better use of data and digital technologies can and should support the, of course, overall health policy goals. healthier people and more sustainable, citizen-centered and transparent health systems, and it clearly can do that. There are three main reasons, in my opinion, which oblige us to make digital innovation in healthcare happen much faster than we have been able to do up until now. Firstly, to start with the most important one, digital tools enable us to provide healthcare with higher precision and better coordination than ever before. Personalized medicine, artificial intelligence enabling disease pattern recognition within minutes based on genomic data used in combination with other relevant data sources to aid diagnosis and to find the right treatment for a particular person is just one example. Individually, having the right data available for the right person at the right time can be a matter of life and death, of course. Collectively, making data available for research and innovation will enable scientific breakthroughs to better predict, prevent, diagnose, and treat diseases. Data saves lives, which is the slogan of the public engagement campaign initiated by the UK FAR Institutes, holds very much true. Secondly, data enables us to steer our health systems in a more transparent and sustainable way, based on the evidence with measurable outcomes to ensure value. And thirdly, healthcare innovation not only benefits our societies by enabling better health, data-driven healthcare innovation also creates opportunities for innovative businesses and contributes to economic growth. So, what does it take then to make it happen? I would like to touch upon a few points that I believe should be the key components if we want to make headway, and they're a bit from, I suppose, more from the perspective of policy making than technology or clinical side of it, of which, of course, there will be a lot of talk during these days. Firstly, citizens' control over their health data. For patients and citizens, digital solutions, for example, mobile health devices and applications, offer easier and secure access to information and the possibility to better understand and manage their own health. This is especially important for people who have chronic conditions, which require constant monitoring. I believe that everybody should have the possibility to manage their own health data digitally, to be able to access, control, and manage health data online in a secure and convenient manner. This also includes the possibility to give one's consent to data sharing in order to benefit from e-services. If we expect citizens to be more responsible in their lifestyle choices and to take a more active role in taking care of their own health, if we expect our health systems to better respond to their individual needs, we must enable citizens' control over their health data and empower them to use it for their own benefit. In Estonia, we have set up a patient portal, an online platform where people can access all their medical records. But this is just the first step in how it should look like in the future. Our aim is to turn the portal into a powerful gateway for personal health data management and for partnership and co-decision making between the professionals and the patients. In addition to the My Health Data repository, it should support people in taking care of their health before, after, and in between the doctor's visits, offering appointments, booking individualized health advice alerts and reminders. Of course, privacy issues are a key part of the debate here, and I've always said that after the time that my personal medical records have traveled to a digital database, I feel that they're much safer there than they were before when they were on the paper, and I had absolutely no idea how did they travel inside the hospital. Nowadays, when they are online, you can check the log files and see who have accessed them and for what reason. So in this sense, contrary to what in some countries seems to be the core of the debate, in Estonia, I can say that data privacy has actually increased with more digitalization because of the robust privacy infrastructure. Secondly, smarter use of health data. We also need to be smarter in the way we use the vast amounts of data that is created both in clinical settings, but increasingly also by people in their everyday lives, using wearables and smart devices to monitor their lifestyles and health or to manage a chronic condition. We need to create favorable conditions for innovative solutions in Europe by joining our forces to open up and join our databases for research and innovation, by constantly improving data quality, and by developing together the necessary infrastructure and analytic capabilities. Let's take the example of personalized medicine. In Estonia, 5% of our adult population has donated their blood to Genome Bank to get their genes genotyped. And 70% would be willing to be part of it should state provide them with such an opportunity. Our immediate aim is to develop and apply in everyday clinical practice decision support systems based on personal health records and genome data analysis. So to link together the data records that are there in one database with the genomics data. Starting from breast cancer screening and prevention of cardiovascular diseases for high-risk individuals, the first personalized medicine services linking these two things together in a clinical settings should be available to Estonian citizens by the end of 2018. Similar initiatives are underway in many other European countries, of course. By joining our efforts and through large-scale cross-border implementation projects, we will be able to unlock the potential of data for health through advanced data infrastructure and data analytics. Thirdly, public trust. All of this, of course, requires public trust. We need to take those privacy concerns seriously, and our task, of course, is to balance the risks and benefits fairly. While privacy and protection of personal data is the highest priority, we need to be mindful that diverging rules in member states would not create unjustified obstacles for research and innovation in cross-border contexts. Privacy concerns are higher in some countries than in others, as I already said, and attitudes towards use of health data differ. According to a recent Eurobarometer study, 70% of Europeans are willing to share their health data, especially with their doctor, while 23% would not be willing to give access to their personal health and well-being data under any circumstances. It's interesting to know that the trust tends to be higher in countries where e-services have been used already for some time and are more widely spread than in those where they are not. If people experience the benefits of e-services in making their everyday lives easier, while at the same time seeing that this is safe, they are less likely to distrust the system. And this has been our experience also here in Estonia, where we have enjoyed a great deal of public trust towards our e-services. A high level of trust also applies to health data, which is stored and exchanged electronically. Our nationwide electronic health record system is in place since 2008 and allows sharing of health data among professionals. 99% of our prescriptions in Estonia are electronic. The centralized paperless system for issuing and handling medical prescriptions introduced in 2010 connects every hospital and pharmacy in Estonia, cutting down on paperwork and doctor visits and saving untold amounts of time and effort. 1 year after its launch, 92% of people who had used e-prescriptions were satisfied with the service. In a 2015 survey, e-prescription service was the most popular e-service in Estonia among the citizens. And while in Estonia every citizen can not only see online who has accessed their health data, they can only restrict access to their data either to particular doctors or altogether. Because of very high levels of public trust, only 0.6% of citizens have used this opportunity. This is why we believe that allowing people to have control over the use of their data and providing transparency about its use is instrumental if we want to have people trusting e-services. But again, I come back that e-health system in Estonia is part of a wider digital society e-governance framework, which means that because there is high trust in e-governance solutions in general, then by extension that also applies to e-health. Fourthly, my next point is about open standards and interoperability. We need interoperable and user-friendly health information systems which allow connectivity of personal health devices and better interaction and information exchange between healthcare providers and patients. I want to stress that interoperability is not just a technical problem. Lack of agreement on common technical and semantic standards in Europe prevents citizens to get the best possible healthcare because different systems are simply not compatible and data cannot move freely. For companies and developers, the resulting reality currently is that markets are way too fragmented for significant investment plans, and that's a problem for the whole Europe. Building on the opportunities offered by the digital single market, we should create favorable conditions for innovative digital solutions to be scalable, for example, by promoting the use of international and open standards. Finally, we need partnerships. In e-health, the European countries have been collaborating now for many years, and important progress has been made in the implementation of electronic health records systems and e-prescriptions. Yet we can do much more together to facilitate the use of digital technologies and new data analytics tools in support of our health policy goals. At the informal meeting of health ministers in Tallinn in July, we got a strong political support for advancing digital innovation in health. The ministers welcomed reinforced collaboration, in particular in areas related to ensuring data protection and information security, as well as interoperability and standards, extending the cross-border health data exchange and building common data platforms to facilitate reuse of data for research and innovation. We have also seen an unprecedented interest by a broad range of stakeholder organizations to work together. More than 100 organizations across Europe expressed their interest to work together on the Digital Health Society Initiative, a collaborative multi-stakeholder movement initiated by the Estonian presidency. Digital Health Society Declaration will be launched here at our conference tomorrow. I invite, of course, all organizations committed to delivering digital health to join this call to action and make their contribution to the attainment of our common objectives. I believe that in partnership across public and private sectors and with all stakeholders, we have the opportunity to speed up the digitalization of health systems across Europe and to take full advantage to advance health in the digital society. All of these topics, of course, will be very much at the heart of the discussions in the coming 3 days. So I would like to end here by quoting Oren Harari, a business professor at the University of San Francisco, who has said, "The electric light did not come from the continuous improvement of candles." So I wish you all courage for change and an open mind in making new discoveries. Thank you very much. Enjoy the conference.
Thank you, Minister Ossinovski. And now I have a great pleasure of welcoming on stage a man who has had over 30 years of experience in healthcare and technology. The President and CEO of Healthcare Information and Management System Society, Mr. Halwolf. Welcome.
Thank you so much. It's good afternoon, isn't it? We've been moving so fast today. First of all, I want to thank you for the warm welcome and to thank the Ministry of Social Affairs as part of Estonia's presidency, to the Council of the European Union and the ECH Alliance for this opportunity for all of us to get together and be taking part of what we know will be an extremely stimulating 2 days, which is already off to an amazing start. There is a competition in Europe and a competition across the world to be the next Silicon Valley. And often Estonia has been labeled as the Silicon Valley of Europe. I think it's almost switching around a little bit. I think Silicon Valley has got to figure out how to catch up, which is a heck of a compliment. But when you look at the foundation of the e-government that is here in Estonia, and the direction in which the world is moving, it is a real tribute to the foresight and the thought that has been such a part of a digital health movement and a digital health foundation literally across the globe. Now, very recently, we had a wonderful opportunity to have the eHealth survey, which covered the European market that HIMSS was able to conduct. And one of the most important points that came up was that only 1/3 of the governments that had been contacted and we had a survey back against actually felt that they had enough money and enough funding and direction towards the use of IT in the delivery of care. And these challenges are not alone. Our systems are going to be continuing to be more constrained. We know this is coming. And this is an economics which is not based just around healthcare, but more importantly is based around all of our governments as we have a silver tsunami upon us, which is growing in our challenges to generate GDP in order to pay for basic services. So the extension of digital health and the extension of care through the use of information becomes an absolute and critical component. At HIMSS, we recently made an important change. We made a shift in our vision statement of better health through IT to better health through information and technology. Now, the IT part of it is so ingrained in us, I almost repeated it immediately myself. But the reality is that by splitting apart information and technology, we're taking into account a fundamental understanding that the technology infrastructure that we have is a critical enabler, is designed to deliver information to us so that a care provider, a citizen, a family member can all share in the information that is upon us. Later this afternoon, we're going to have a conversation with the Microsoft Cloud Council as an example. And we're very interested to see how can that information and data be available and be exchanged across borders in order to promote the use of health and information in a timely manner. Our goal at HIMSS in the next couple years, and starting immediately, is to elevate our understanding and the use of information with the provider, with a strong technical background, and reaching out to the citizen, the patient, and the consumer, all three of which show up the moment they walk into an exam room or the interface. They wear all three hats simultaneously. The patient looking for some service, the citizen with expectations of how those services will be delivered, and finally the consumer who is looking for them yesterday, immediately, and wondering why the heck they even had to leave their room to go and get the services they were looking for. These things are coming together and challenging us every day. I hope many of you will join us at HIMSS 18, which will take place in March in Las Vegas, where over 45,000 people will come together to see literally the largest ecosystem display of healthcare, and walk in with 3 things on your mind, and potentially walk out with 6 that we can bring back and have a wonderful discussion at HIMSS Europe 18 in Barcelona later in May. Our goal is to bring these services, capabilities, thought leadership, and descriptions right to the local level as a part of our calling to improve health and deliver better health through information and technology. So again, thank you so much.
Thank you very much. And to conclude our opening session, I invite to the stage Mr. Brian O'Connor, who is the chair of European Connected Health Alliance, and he has experience in setting up many private and public health services and overcoming those barriers that innovation brings to the health sector. So, Mr. O'Connor, stage is yours.
Well, thank you all very much. It's a real honor to be here, especially as the Estonians have proved yet again that when I was here in, I think, April, this building was here, but all of this was not. And they kept assuring me that everything would be fine for October. And I want to congratulate you for doing nothing else. You've managed to get this building into shape. I think the fact we're in an old building, the fact that they haven't given up on an old building and transferred us to one of the many purpose-built conference centres is an indication of the attitude and the spirit that we have encountered and experienced here in Estonia. We're here as the ECH Alliance, as a co-organiser of the event, but more importantly, as the strategic partner to the Estonian presidency. Together we work on the Digital Health Society, which the Minister mentioned. I have to be honest and say that the reaction to the idea of the Digital Health Society has surprised us. Like so many initiatives in Europe, you can get people interested, excited, and then they move on to the next one. So I wanted to publicly thank, and there'll be more opportunities over the next few days, all of you who have participated in the webinars, the public consultations, and particularly those people who have led and participated in the task forces which have tackled real issues, not the blah blah issues, not publishing papers, but rather roadmaps and directions and milestones and timetables for doing real things. The Digital Health Society is about citizens. It's not only about patients. I often smile at conferences when people talk about patients as if somehow they were a different part of the human race. All of us, at least maybe all of you, will one day be a patient. But the reality is that we're trying to focus on what the citizen wants. It's not a mistake or by chance that the Wi-Fi code and the network. This was, by the way, not part of the presentation. It's an attempt by the sound people to tell me that I've got 2 minutes, 51 seconds, and also to see if I can cope with that. So being an Irishman, of course, I can cope with just about everything. Particularly as Northern Ireland just qualified for the playoffs of the World Cup. Other countries didn't manage to do that. I thought I'd just mention that in passing. And even Iceland managed to make it as well. So let me just finish by saying this. We're proud to be associated with Estonia, proud to be associated with the presidency, absolutely thrilled with the determination, the enthusiasm among all of those of you who have participated. Tomorrow we will be signing the declaration, which is public now. You'll be pleased to know that some people are already signing this online. You can do the same. Because remember, this is not about leaving it to the next person. This is about if you don't do something to make your lives, your family lives, and your countries better equipped to deal with this fifth freedom, then the failure to do that will be yours, not the next guy. So sorry to be as blunt as that. Well, I'm not really sorry to be as blunt as that, because that's the way I am. I see many friends in the audience, and I want to say to you that we have started. We have a long way to go. Only you can make it happen. We, the Alliance, will do our best to assist you in doing that and trying to make sure that we continue the good work that has started with the Digital Health Society, but we need your help to continue to do that. The very last point I'd make is, you've noticed the very large chairs on both sides. You notice the colours. The red one is for those people who have failed to do anything worthwhile by the time the conference finishes. So you can gather there for a loser's photograph at the end of the conference. For all of you who are undoubtedly energized and excited and all the rest of it, we can all gather round and help each other up onto the chair. So that's a challenge for you by Wednesday. But in the meantime, I really do think this is going to be a conference that does things, not just talk about maybe doing something. Thank you for listening.
Thank you, Mr. O'Connor, for this Irish touch to our conference. And we are really glad that we had 3 days to discuss those issues. And we're trying to be very punctual at this conference. So this opening session will not end those questions and answers, because you have a chance to ask those questions in many more other sessions, many other places. And in this hall, we are concluding a session now. We have a 15-minute break, but then after break, we will divide our audience into 3 groups. So. Mm-hmm.
And I'm also glad that we happened to choose the blue chair. Whew. Okay, so upcoming sessions at 13:45 Estonian time. In this place, Engine Hall, we will have digital health around the globe.
And the other session at the same time is in a room called Power Station. You'll see the signs where it's located. And this one is about redefining the stakeholder partnerships and business models. So more about health business.
And there are, by the way, living signs to help you out if it's a bit difficult to navigate. But in the steam room, which is situated in the downstairs, there will be a seminar called Blockchain, Unleashing the Power of Free-Flowing Data. And this is also the reference to the fifth freedom.
And we are expecting you all back here in this main hall, in the engine hall at 15:15. And in that session, we'll hear, among other things, a video speech from our former president, Toomas Hendrik Ilves, who is a fierce voice in the digital world and IT sector. He's a professor now at Stanford University, and he will address us from California at 15:15 back here. But now 15-minute break and then 3 sessions.
See you later.
Ladies and gentlemen, welcome back. I hope you've all had something to eat and drink. I haven't, so I need you to feel sympathy for me. But we have a very interesting session now, which we, the Alliance, have been starting to create in different parts of the world. Recently, about 2 weeks ago, we had a digital health around the globe session in Beijing, China. And it was fascinating to hear the contrasts about what stage everyone is at in their development of digital and e-health. And I think from listening to others, we can often learn surprising lessons. I was quite surprised at how far advanced the Chinese are in certain areas. And they will tell you they're way behind in other areas, which of course creates an opportunity for all of you in this room if you want to do business in China. So we have a distinguished panel today. They tell me that they are very disciplined. They will stick to their time, and we shall see. But I know all of them, and I think that you can be assured that they're going to give their own views quickly and succinctly, and then we really do want audience participation after that. There's an old rule that we have in the ECH Alliance, is if the audience doesn't ask us questions, we will ask you questions. So I really prefer to come from you. So do think and make notes as we go along. So I will introduce them as they come up to speak. Then as each finishes, they'll return to their seats. When we've finished the panel, we will then have time for questions. I hope quite a lot of time, actually. So we're going to begin, first of all, with our representative from India. And he's been trying to teach me how to pronounce his name. When you look at the English word, it is harsh, H-A-R-S-H. That has one particular meaning in English and apparently a similar meaning in Hindi. But in fact, I'm going to attempt it again, but in any event, just come up to the stage and speak. His name is Hirsch, no? Not bad. So perhaps you'd join me in welcoming our representative here, Hirsch from India, to start the process, please.
Yeah. Okay. Good morning, ladies and gentlemen. I am here from India, and I want to explain you quickly about the health perspective in India, specifically about e-health perspective in India. But before coming to that, let's discuss India. Let's quickly get the facts about India clearly. And this will help you understand the e-health initiatives that the government is taking and the innovators are doing. So India, as we all know, is second most populous country in the world, and it's crossing 130 million mark. It's one of the fastest growing economies of the world and 7th largest country in the world. So I practice in an area called Chandni Chowk, which has a population of 14 million, which is higher than the population of Estonia. And the size is 10 square kilometers. So you can understand the population density and how the cramping up is done. Now, Estonia's size is approximately 45,000 square kilometers, and in Old Delhi's Chandni Chowk size is 10 square kilometers and a population more than Estonia. The average age of population is around 29 years, and dependency ratio is 0.4. All the population is very young, and there are 2,000 ethnic groups. Every major religion and language family has a presence in India. So to understand health perspective and to explain you more properly, I decided to visit home of one of my patients who resides in the Chandni Chowk area only. And there is a short video that you all must see. I want to take you there in India, how two different Indias exist. One is the developed India and other one is in the process. So this video will quickly explain you the perspective.
Hello, people. Welcome to Estonia and Tallinn's e-health conference.
Hello to everybody and welcome to Tallinn, as Mario said.
My name is Marjo Näkki. I'm a journalist from Finland who's been living in Estonia for years and calls this tiny city, beautiful city, her hometown. I'm working at the moment in Moscow as a correspondent for the Finnish broadcasting company, but I'm always so excited to be back home.
And I'm Neeme Raud. I'm another moderator who will be guiding you through these 3 days here in Tallinn at this conference. I was a news anchor at the Estonian National TV, and I was a correspondent in New York and Moscow before. And now, e-health. Estonia is really proud to have this conference because during our presidency in European Union, the e-services IT sector is our focus. And in Estonia, we have experience to share with you in that field, and we hope the conference will be very interactive. You have always chance to ask questions.
चला नहीं जाता मुझसे मैं हिम्मत करके चले जाता हूँ नीचे बैठूंगा आराम लूंगा फिर ऊपर आराम से चलूंगा जीने पे रुक जाऊंगा फिर चलूंगा जब आता हूँ ऊपर कहाँ मिलती है पूरी दवाई माँ नहीं मिलती पूरी दवाइयाँ नहीं मिलती वहाँ पर जांच वाले गए वो कई हज़ार रुपये बताए तो होगा सीटी स्टील का और सीपी का काम करता था मतलब बफिंग होती थी फिनिश बफिंग का वो करता था निकल कुरुम भी होता था नहीं अब तो मेरा मतलब ही नहीं है चल उतर जाता हूँ चल जाता हूँ यही बहुत है दवाई लेने दुकान पर जाता हूँ 6 3 हमें और 3 वो बच्चे और हाँ वो जावेद भी है उसकी भी एंड है वो दर्द है पैरों में हाय हाय करता है वो और वो भी है उसको और क्या बोलते हैं उसको बहुत शील का साहब आंटी का जोड़ों में दर्द है उनके और क्या नाम है वो भी है शुगर भी है उनको दवाई और काफ़ी खर्चा होता है भाई कोई हिसाब ही नहीं तो ऐसा है ना दवाई में तो 500 की आ गई 1000 रुपये की आ गई अब हमारी आती है 1000 रुपये की दवाई आंटी की आती है 500 रुपये की दवाई बच्चों की लगी हुई है
Hello, people. Welcome to Estonia and Tallinn's e-health conference.
Hello to everybody and welcome to Tallinn, as Mario said.
My name is Marjo Näkki. I'm a journalist from Finland who's been living in Estonia for years and calls this Hello, people. Welcome to Estonia and Tallinn's e-health conference.
Hello to everybody and welcome to Tallinn, as Mario said.
My name is Marjo Näkki. I'm a journalist from Finland who's been living in Estonia for years and calls this tiny city, beautiful city, her hometown. I'm working at the moment in Moscow as a correspondent for the Finnish broadcasting company, but I'm always so excited to be back home.
And I'm Neeme Raud. I'm another moderator who will be guiding you through these 3 days here in Tallinn at this conference. I was a news anchor at the Estonian National TV, and I was a correspondent in New York and Moscow before. And now, e-health. Estonia is really proud to have this conference because during our presidency in European Union, the e-services, IT sector is our focus. And in Estonia, we have experience to share with you in that field, and we hope the conference will be very interactive. You have always a chance to ask questions.
Find first point contact. I mean, the first point of a patient is not a primary care physician. A patient chooses to visit tertiary care center, which leads to overwhelming crowds at even the highest premier institution of India, which is All India Institute of Medical Sciences. And the public reach out program for healthcare is very poor. The accessibility of healthcare is also very poor in India. As the video particularly explained, patient faces a lot of problems reaching healthcare facility. There are only 0.9 beds per 1,000 population. And doctors to patient ratio is 1:1,700 against the WHO guideline for 1:1,000. Nurses to patient ratio is again 1:40. Now, nurses to patient ratio is particularly important in curtailing down the mortality of healthcare. In India, around 20 million people reach below the poverty line because of catastrophic health expenditure. Ladies and gentlemen, 20 million people each year enter below the poverty line. It means they cannot afford their daily livelihood. They enter a vicious cycle of disease and poverty. People are forced to sell their lands and means of livelihood to get themselves treated. In India, there is high out-of-pocket expenditure, close to 67%, although some data suggests around 58%, but it's close to 67%. And this high out-of-pocket expenditure is mainly for OPD cost. Out of 100 patients, if they choose to visit hospital, around 70 patients, they spend out-of-pocket on their OPD visits, and even in OPD visits, it's on the diagnosis and the drugs that they take. Quality in particularly is poor because of all the three other factors. Since the accessibility, awareness, and affordability is bad, the quality is bound to be poor. There is only 4.0% expenditure of GDP on healthcare, out of which government health expenditure is 1.4%, just 1.4%. And rest all is being borne by people themselves. We all very clearly know that high out-of-pocket expenditure means poor standards. There is a non-standardized financing. But this is not all. India is a mixed bag and it's changing rapidly. And we wanted to showcase you how the situation is and how rapidly it's changing. We will quickly go through the Advantage India and the policy initiatives that the government is taking. So India's healthcare sector is growing by all modest means at 17% compound annual growth rate. India's healthcare sector is 5th largest employer, both directly and indirectly. And in fact, it employs 4.71 million people directly. It is expected to be in top 3 healthcare markets by 2020. Last year, only 1 million medical tourists visited India. India is a hub for medical tourism and a regional player. Medical tourism has a compound annual growth rate of 27% and it's poised to reach $8 billion. India is also a hub of clinical research, and there is advantage in investing in India. There is 100% FDI allowed, foreign direct investment allowed in India. It is also home for one of the best medical education standards. In fact, 25% of healthcare providers in US and UK, I'm talking about doctors here, are from India. And the most important factor for the industry's growth is that 74% of market share in healthcare is provided by the private sector. Keeping in view of the challenges that a patient faces, in terms of accessibility, affordability, awareness, and quality. And given the advantage, government has taken several policy initiatives. There is an increased emphasis on mobile health. There are various programs which are focusing on mobile health, like diabetes screening. There is a restructuring of National E-Health Authority. And national health policy clearly explains the need of a health card, a unified comprehensive health card. There is a complete thrust on UHC coverage, universal health coverage. Government health expenditure is bound to rise from 1.4% to 4% of GDP by 2020. Now, the financing of healthcare in India is done partly by center and partly by state. And health is a state matter as far as implementation is concerned. So both center and state, they collaborate and contribute in the financing of healthcare. There are several examples of e-procurement models being implemented at various levels. There is Skilled Sector Council in India now focusing on healthcare. And innovation is around procurement. So when we talk about e-health initiatives, we want to categorize them in two definite outcomes. These are clinical outcomes and governance outcomes. So as we all know, clinical outcomes, it helps in early diagnosis. There are expert opinions. It helps in better patient monitoring, better compliance. It is highly data-driven. It means high quality. It's a very good research tool, and awareness and response around e-health is amazing as far as clinical outcomes are concerned. One most particular advantage of e-health is the governance outcome in a country like India. So in governance outcomes, it leads to unified approach. That means the government can approach the health schemes, they can monitor the health schemes, they can do the beneficiary tracking, they can do the procurement decisions, which are data-driven and demand-driven, they can do the performance check and human resource management. We will quickly go through the case studies. So government's initiatives we must discuss. There is a website called data.gov.in, which clearly links all the data of healthcare on one unified platform. Anyone can access it. There is mother and child health tracking system, which is more particularly important given the high maternal mortality ratio in certain pockets of India. This is a demand-driven e-procurement model adopted by Maharashtra, which clearly fills a gap. So there is Central Health Resource Database by Tamil Nadu. diabetes. I mean, diabetes is an epidemic in India, and it's growing in fast numbers. To track that, government has formed diabetes. A person with diabetes can access healthcare through mobile. There is a complete health deck, including all the information by one state called Andhra Pradesh in India. There is one particular example of AIIMS OPD transition. I showed you in the video that even the most premier institution, AIIMS, was highly crowded. Now that has transformed. In last 2 months, Tata Consultancy Services did a pilot in AIIMS, and now patients can receive SMS for their future visits. They can receive SMS regarding their medicine consumption, etc. We will quickly discuss the innovations. There is a device called Fundus on the phone. It's a complete Indian innovation. Fundus cameras, as you all know, are very costly, and in a country like India, where accessibility to healthcare is very poor, it quickly clicks the photograph of fundus and sends it to the ophthalmologist for the analysis. There is a hemoglobinometer. Given the anemia situation, it's particularly important. It's a point-of-care device. There is one company called DigiBridge, which is working on remote slide analysis, particularly important for oncopathology. There is intelligent prognosis by Cloud and Care, including data. In fact, the world's smallest ventilator was recently developed by an Indian doctor at All India Institute of Medical Sciences. It's this smaller device and can solve a lot of problems. There are solutions around remote ICU management. While we discuss that, we must discuss the opportunities that Europe and India can work on together. This is particularly important when we are here at Tallinn, which is considered as Bay Area of Europe. We must work together in technology transfer, which is particularly helpful for volume-driven models. India is a hub of regional healthcare in Southeast Asia, and various people from various countries, particularly Bangladesh and Pakistan, visit India for high-end healthcare. Aadhaar is a particular opportunity which compiles all the data of patients and scheme dispersal, and this will be a very important tool for data analysis and predictive value once it's linked properly. Thank you so much. This was a brief overview of India and its e-health initiatives. Thank you.
So we promised to bring you some of the contrasting things from different parts of the world, and I certainly think we have had an experience, particularly through the video, of seeing the contrasting and the reality. We have to face up to reality sometimes, even if we don't like it. So we're moving on then to our speaker from Spain, Jordi Serrano, who's a doctor, and he's also going to represent here the universal doctor, which seemed to fit very well with our topic. Jordi.
Thank you for inviting me to talk today. I will try to be very brief. Pascal Ladier invited me to talk, and Brian also, and just thinking to talk about maybe Europe, maybe Africa, maybe Latin America, and why? Why that? Because we've been working with our project called Universal Doctor for many years. We started the project like 10 years ago in my surgery when I was a medical family doctor, because I had many migrants from many different countries and we didn't have enough money to have translators. And basically, we implemented that. Do you remember there was a technology called Flash technology, Flash, with CDs? Imagine, before the first iPhone was there. So we were like a startup 10 years ago. I don't know if we were still a startup, but we were there, no? And we were lucky because when iPad came, we were the only maybe few groups of doctors that we had a package, and we high rocket very quickly. And we were able to implement these tools, a translation tool, in 150 hospitals, the web version, no? And then we started working in many different fields, specific silos. Obviously, nurses were the ones who were using the tool. Let's say, come on, Jordi, we are the nurses. It's called Universal Doctor. You can call it that way. You must call it Universal Nurse, no? And then, obviously, we were just customizing it. We did for pharmacies. We did many governments, Belgian government. We tried even to implement also in Norway with the Somali refugees and many other countries. Many pharmas did specific tools, etc. No? But basically, what we did is also start to work in a very social approach, and that's why we moved to Geneva, where we start working, collaborating with many NGOs and with the World Health Organization slowly. And for example, we developed some tools for specifically situations like the outbreak of Ebola. We open source our platform to be used for the translation for outbreaks when the Ebola happened. And of course, obviously, with the refugeespeaker.org, which we are working with the IOM, International Migrant Organization. And obviously, our illusion always was to work socially oriented. And then we start, without even noticing, to work with the World Health Organization in different projects in Africa mainly and in Latin America. So we have that vision of how we're testing new things, failing very quickly if possible, and confronting the different interoperability problems in different places and thinking, oh gosh, how difficult it is. But then just giving you examples of how even reverse innovation could help here in Europe now, no? A little bit that's the way we've been working the last years. Well, we've been working, as I told you, with the World Health Organization, London School of Tropical Medicine also, and other governments, international organizations. We launched the Zika app, no? The Zika app during the crisis. It was amazing that the organization like WHO in just 15 days was able to do it. That's for a nice, for a bureaucratic organization, which it has to be a bureaucratic organization, to launch something in 15, maybe 1 month was amazing, no? Even was the magazine say, WHO is rivaling with CDC, so they were very happy to be on the track to innovate. International organizations can also innovate. We did many other apps. Basically, the important thing collecting data apps using many of the open source technologies, Open Data Kit and OpenMRS. I will explain you later very quickly. But basically, apps can be used everywhere if you have a clear focus in what are you looking for, and if you use it and you work with the local government. No? For example, London School of Tropical Medicine did a huge data collection with the Guatemala government to gather information about disability. The problem was that in Guatemala City, it's very dangerous to knock on the door and ask. So we had to basically work in a system where surveyors had automatically the control. So they had a person, 25 years old, but automatically after making that survey, a control of the census would appear in their tablet offline, just to know in which place he had to go, that surveyor. No? It was very interesting how technology can help for some situations. No? We launched on Monday, we're very happy, the Mental Health Gap Intervention Guide app with the World Health Organization. It will be also multilingual. It had to be, and this is a very crucial point because there are no psychiatrists anywhere in the world, almost outside Europe and America. And mental health is huge. It's important. It's the most important burden of disease, probably not attended. And we are launching it with algorithmic diagnosis and many other treatment, assessment, and management plans. It's very simple. People that have not maybe the right formation can follow up the algorithms and the assessment and management tools. Blockchain, also, we are, with the World Health Organization, is thinking to use blockchain for the identification of legal transplants, which would, at the end, if extended, would mean that at the end, if that is extended, if you don't have that ID number confirmed by blockchain, you are maybe in an illegal situation. No? Thinking very quickly to use all these technologies. We ourselves, okay, we have like a double arm, two arms. No, one arm that we have to earn our life. We have like 10 engineers. We have like a kind of a crazy team scattered around the world. So we have to earn our money, no? But then we have also that social approach that obviously it always return our investment in new projects and new learnings. No? We launched a project called Zero Mother's Day to reduce maternal mortality in Ghana. It was so successful at the beginning, and then we failed, basically. I have to be honest with you. We did something very interesting in imagining a ping phone, because we were just prototyping in a remote area, and I was angry because some husbands stole the phones of their wives. And I thought, okay, we're going to make a ping phone. So if you steal the phone, maybe if you are biking with the phone, so everybody will know that you are stealing the phone of your wife. No? And it was super successful. Where? In New York Times, where in Geneva, wherever, in magazine, wherever. But of course, then when you have to implement a project in the field, unless you are working very close with the government, and we were, but they decided at the end that it was not sustainable to have a ping phone for each woman, no? Each woman. In any case, it was a very interesting project, and we learned a lot. And now, for example, 3 weeks ago with Republican Dominicana, we already did it more straightforward, a small MOU. We had that tool called Zero Mother's Day, and we are just working with the Republican Dominican government to translate that tool in Creole from IT, because there are many people from IT crossing the border and delivering there. So this is a very nice tool where you can have messages every week of your pregnancy, delivery, and all that. No? Many things, blood pressure, under pressure, NCDs, non-communicable disease, and neglected disease is what is called dual epidemiology. Okay, it's now developing countries are skyrocketing with NCDs, chronic disease. It doesn't mean that we have to forget the neglected disease because still they are there. It's a dual epidemiology, and people should not be competing for grants on blood pressure and on malaria. No, both, because the patient has both. No, so all these things we're working with different actors and very nice chatbots to put all these tools together. How we can put the patient in the center in the flow. Chatbots could help a lot. We are launching a platform together with some friends of France, with with Jacques of France that they're developing chatbots for health, and we are specifically developing chatbots for public health, where we will give a platform to everyone to create a chatbots without any knowledge of coding. We have a dashboard where you will be able to put a sentence, an answer, a video, etc. No? And then send that to Facebook, send that to any platform. We are launching that very soon. And I think it's very interesting. Where I come from Barcelona, the government, of course, like many other governments, personal health folder. But of course, the citizens must get engaged. And why not these governments that are doing a very wonderful, good job are adding new technologies, no? Semantic voice recognition, etc. We know, you know more than I, all this history of EPSOS, the cipher, all these things that happen. But all these, if patients are engaged but not enough, these things will not take off, no? And I think that the big effort that all these organizations have done needs to be a very nice thing I discovered that some patients are recording their own encounters, obviously in a hidden way. No? So if patients are doing that, doesn't mean that maybe the personal health file could be able to do it. No? I mean, voice recognition, semantic will change everything. Very quickly, 1 minute of voice, many things that can really trigger a lot of technologies when we are, of course, last 2 weeks in Health 2.0 in California, Santa Clara. American innovations are amazing, no? But sometimes you have front end with Epic, fantastic, but well, it needs to improve, no? The front end capabilities. Doctors are tired. If included, no? If you can include voice, that will change everything, no? The day that voice can be included. A lot of innovations that will transform the system into auto-diagnostic tools. No? MicroRNA, many other technologies that will make possible that people can diagnose themselves. It doesn't mean to forget about doctors, but many technologies will help of that. An example of, in Africa, developing countries, interoperability sometimes is quicker than in other developed countries. No? The system OpenMRS was born in 2004. Now it's connected with OpenSRP. DHIS2, it's connected with them. DHIS2 was born here in Oslo, OpenMRS in Boston, but then it was implemented in these countries. And now, for example, we are developing an app also multilingual. The Universal Doctor is multilingual, but then we like to do things. M-Palliative app that will be implemented in Zambia, in India, and in other countries. We're not thinking in developing it with any technology of Europe. We're thinking to develop with technology of that technology. And we're thinking to implement the M-Palliative app in Europe as a reverse innovation with these technologies. It's easier, no? It's more interoperable. And I think 2 weeks ago, Google voice recognition, of course, Fire APIs. Many things are advancing very quickly, no? But in different perspectives, the systems are quite different. But if all are finally integrated, will help a lot. Chatbots will help a lot. Some technologies can be used in both sides, no? Direct observed therapy for tuberculosis, for many things. But here, there's a huge amount of waste because of not taking the medication, no? So many platforms already exist and should be used. Onrom, Alifcore, they have tremendous devices working out together. I think the patients will get engaged slowly. I'm finishing. And how systems, we must think in systems that can work here, can very quickly work in the developing countries. IFC of World Bank launched a medtech platform to implement very quickly in India projects that works. And yeah, I will finish very quickly. If not, Brian will kill me. But many things can really trigger finally what we've been all of us waiting all these years. And it's the moment to really use all these systems. We work together with Health 2.0. Now that HIMSS has acquired Health 2.0 conference, we work together also with conferences that really help patients to get these products in their hands. Thank you very much. Thank you.
It always amazes me how much is going on in the world. So that gives you a very, very quick journey around the world. Moving on quickly, because we want to try to catch up some time to our next speaker, And I'm delighted to have the opportunity actually to introduce Joe Kvedar, Dr. Joe Kvedar from Boston. I'm not sure I need to say much more about Joe. Joe.
Thanks, Brian, and thank you to the organizers for inviting me to stay with you for a couple of days and deliver some U.S. perspective to this EU event. It's really been a pleasure so far, and I've learned a tremendous amount. In fact, listening to my colleagues, I'm reminded now of how broad the concept of digital health has become, and my own perspective on this comes from 23 years of experience in telehealth, of espousing and pushing the vision that healthcare should be delivered in a time and place independent manner. So my remarks are going to be focused on that sector of digital health, and I'm going to talk about adoption in the US and some of the challenges. My background is that I'm in Boston. I am a physician. I'm also overseeing telehealth strategy and implementation for a delivery system called Partners Healthcare, which is anchored by the two largest teaching hospitals of Harvard Medical School, the Brigham and the Women's and the Massachusetts General Hospital. So that's my context and my perspective. And I would say the US market is somewhat fragmented. Brian asked us to talk about the population that we're dealing with. The US population is about 320 million. But I think the important concept here is how we offer them healthcare services. About 50 million of those are on our government-sponsored plan for the elderly and the infirm called Medicare. Another 50-ish million on Medicaid, which is largely a state-level program for less fortunate individuals. But 155 million, so more than double any of those and triple, are insured through their employer, and that's through our private health insurance network. So you set up immediately a sort of, I think, confusing a set of markets in which people can deliver innovative e-health services. And that's, when I was reflecting on putting this talk together, I thought that's probably the reason that, in my opinion, I think our adoption has been wanting in the US. Because as people come up with innovations, they sort of, I think, struggle as to how to get them into the mainstream. So on the one hand, if you're going for that 155 million person market that's insured through your employer by a health plan, we have all of this stuff that we can do, and people think, aha, I can go around that stubborn doctor, that group of professionals that doesn't seem to be wanting to adopt anything, and go directly to health plans and directly to employers, and you get concepts about wellness, fitness, so trackers and mobile apps and all those things, and there's a tremendous amount of innovation there, but it's quite fragmented, and there's no clear winner that I can tell you, oh, this is being adopted and it's pushing forward. There's innovative health plans, innovative use of wearables, innovative use of apps, but once again, I don't see anything where I can say this is the true future of that industry, because it's very crowded and it's very fragmented and it's tough to sell into that market. Perhaps harder, however, is to sell into the other part of the market. Now, if you're selling to the market that's insured by Medicare and Medicaid, you're really selling to healthcare providers. And as I alluded to earlier, we're pretty tough customers, and we're pretty tough in terms of being able to actually adopt innovations. I will digress from my script for just a minute and talk about one other digital health innovation that's not connected health, and that's EMRs. And I'm sure all of you know that about 8 years ago, our president decided to push forward as part of a stimulus effort for the whole economy, an adoption of electronic records. And while there's been now basically universal use of medical records by our physicians, most of us dislike it intensely. And that's a really sad comment on both the products that the vendors are giving us and the usability and the way our government decided to implement that program. And I'll leave it at that. But the reason I bring it up in this context is it leaves a sort of sour taste in both physicians' mouths and our patients, because patients now come in the room and they sit and they watch us type. Or if we're sick of typing, we actually hire scribes now. So bring in a technology to make us more efficient and hire people. That's where we are with EMRs in the US. It's kind of a sad comment. So back to innovations, and let me tell you some good news, because I didn't come here just to squawk. Virtual visits is really taking off. And it's interesting because we haven't figured out the business model yet, but we're in this phase with virtual visits where everyone feels like they better get there because of fear of missing out. And if you're someone who espouses that kind of care delivery, this is a wonderful time because people just want to do it. They don't want to pay too much attention to the particulars and the business models. Most of my colleagues that are pushing this hard, other brand systems like Cleveland Clinic, Mayo, et cetera, they don't quite know how this is going to help them, but they know it's part of the future and they're pushing it hard. So virtual visits with your provider is becoming a thing in the US, and that's exciting. The downside of that one is it's not really very well integrated. Most of the time, you don't get your doctor for a virtual visit, you get a doctor. And most of the time, the integration between the EMR of the virtual visit and your own doctors is loose, if at all. So it creates a separate channel of healthcare delivery. I like to think about delivery of services. I use companies like Uber and Lyft and sometimes retail pharmacy in the US as examples of how you can really tightly integrate digital experiences with face-to-face experiences, and we're a long way from that when you look at virtual visit delivery in the US. When I look at wearables and their involvement, well, again, there's some good news, again, on this health plan side of the market, where companies such as United Health Group are making a big push to use wearables to actually give people back money into their health savings accounts if they meet certain behavior targets. So there's a lot of innovation going on, and you might even say some at scale when there's several 100,000 people on that particular program for United Health Group. But I don't think it's far enough, fast enough, and I plead with others to move as fast as possible to try to catch up. And then finally, remote monitoring, which is one of my favorite uses of technology to actually change the way that chronic illness is managed by keeping people healthy in their home, is also taking off to a degree. But again, people are so, I mean, it's not only confusing the business model on that one, but it's like, what do I do as a doctor if I can't bring you in? That's the way I get paid. You come, you see me. And it just sort of is languishing as people try to figure out how doctors are going to get paid for their time. And again, it's not a visit, so that's disruptive. It's quite a challenge, I think. Now, the last one I want to mention is some physician barriers, because I've spent quite a bit of time in the last months working with the American Medical Association to try to alleviate some of these. So they fit into 4 categories, if you're thinking about this. Category 1 is evidence. Does it actually work? There's still a lot of skepticism in the physician community that these innovations are actually going to deliver health outcomes. We could argue there's evidence, but there needs to be more, some people would say. Will I get paid? That's the reimbursement piece. Will I get sued? So that may be unique to the US, but there's a lot of fear of liability. And will it fit into our my practice workflow? And I think you can choose of those 4. They're all important. Now, when I get to the hospital side, and I'll close with this thought because it's just come up. And so the good news is, as we start to lift these things from the sort of crazy innovation space to the start to mainstream space, certain things come out. And hospitals, remember, are buildings. Fundamentally, they're not unlike hotels in some ways, and they have to pay the rent on those buildings by filling the beds. So if we envision a world where we can actually deliver care virtually to a great percentage of our patients, which is what we all want, hospital administrators start to worry about how they're going to cover the overhead of their brick and mortar. And that creates some adverse incentives for them to be able to push forward some of these programs. And we've seen that in our own delivery system as well. So I think the perspective from the US is mixed, quite frankly, and I'm being completely honest. There's a lot of initiative. There's a tremendous amount of innovation. It's kind of fragmented. It's kind of scattered. And I wouldn't say there's any one leading application that I can point at and say, this is pushing us forward to that final frontier of being able to deliver care time and place independent, where it's needed, when it's needed. Thank you.
Thank you. Whistle-stop tour of the US market. We're moving now finally to Australia, which is a long way away. And if Laurie, could you come up? Laurie's going to give us a very brief overview, and we're tight for time as always, Laurie. So he has an Australian accent, but he does agree to speak slowly during this, rather like I do.
And
Thank
press
you.
the button, is this one?
I'm assuming so.
Oh, good. Good afternoon, everyone. How are we? Hi. Hi, come on, a bit more. I'm Laurie Hawkins. I'm the CEO of Health Services Directory in Australia. And I'm here to give you a bit of an overview with regard to data interoperability, innovation. Good. You're actually smiling. Be ready. Very quickly about myself. We're here about data. We're here about bringing it together. Nobody can. God knows why. Simple. We'll go through how we do it in Australia. To myself, I've been a successful project manager of what's called the Victorian Human Services Directory, which we'll get to in a minute. I've also sold the concept to the ACT, Australian Capital Territory. Oh, I'm asking to introduce around Australia. 24 million people. It's a continent the size of Europe. Takes 4 hours to fly from Melbourne up to Darwin. And just a little hint, you can tell everyone when you go back, we have the largest population of camels. We do. And I've also been responsible for what I'm about to show you to the federal government, states and territories. What are the challenges? And I'm not going to read PowerPoints. Basically escalating demands, aging populations. You all know, we're all here. Our current trajectory is not sustainable. Funding and everything else. Bottom right, as Joe put today, 19% of GDP is spent in America. That is appalling. It is not sustainable. What do we have? Data in abundance. Do we use it in healthcare? Specifically, no. We are a decade behind. Google, Amazon, they all take that little hint. I want to make booking in Estonia, and they will personalize it straight away. Do we do that in healthcare? No, we're appalling. It's a byproduct. I used to be a manager of a hospital. We had 7 kilometers of paper. What an appalling use of data. It is. Every person who comes in generates 70 sheets of paper. Paper. Gee whiz. Do we use it? It's an incredible opportunity. Yes, we have all these individual little niche applications, wearables. Let's get to the fundamentals. Barriers. Oh, it's too hard. It's too difficult. We can't do it. What a load of poppycock. Excuse my French. Anyone for France? Ah, excellent. And then we have a lack of collaboration and coordination. It's just too hard. No, it isn't. People make it hard. So what do we want to do? We want to bring all these islands of data together, as we had in Wonderland tens of billions of years ago. So what we did in Australia, provider directories. They're address books. They're embedded in your local doctor, your main hospital systems, everywhere. Massive replication of data, time, and effort. That is appalling. When is somebody going to wake up? We did in Australia. Not only that, it's only about GPs. We want directories for not-for-profit organisations, public, private, in the cloud. Isn't that a smart move? Operational information impacts all of what you can see there. Is there a better way? Yes. Service directories. We have the same problem in Victoria, a state of 4 million in Australia. But we also have housing services, social services. So what do? We created a services directory of health and social care, whatever you want to call it, human services. Not only that, we have opening hours, billing arrangements, secure identifiers. What you can see in yellow is a search to find a female doctor, Chinese, who speaks Mandarin after hours. Why can't you do that anywhere else in the world? This is a consumer website. I've been responsible for creating a national health services
The good news is we're very close to a coffee break. And I don't know about the rest of you, I'm exhausted. Thank you for your energetic presentation. All right, I've heard it recently in China, and I think the Chinese surrendered during it and said, we'll buy whatever you're selling. So we have very little time, but I would like to just ask, does anybody have a burning question? So rather than everybody come up on stage again, is there anybody with a burning question which you'd like to ask? If not, we're going to go to the coffee break. No burning questions. All of these gentlemen will be, it's slightly worrying they're all gentlemen, isn't it? I'll be getting complaints soon, and I can see someone looking at me already. Why are there no women on this stage? Ask the organisers. Julian is the organiser. So thank you very much. Please thank the panel. Thank you very much indeed. Thank you. And coffee is served. I'll get in ahead of you all. Thank you.
The second main session of today. I hope you've had a wonderful and inspiring time in Estonia and in Tallinn, an e-health conference. And I do hope that you have been very, very active in tweeting, #eHealthTallinn. So please use that opportunity and tell the world what we are doing here today.
It's already a late afternoon, past 3 o'clock, but our conference will continue in a full speed. But your day will be very interesting and long today. You'll see in the evening very magnificent place, Estonian Seaplay Harbor, which is one of the most magnificent places of that kind in the world. So that will be the conclusion of the day, but we will continue now with the work of the conference. And I'm really honored and happy to introduce you via video link our former president, Mr. Toomas Hendrik Ilves, who is a fierce advocate of the IT solutions. And as he mentions in his speech that is recorded in Stanford University in California, where he works now, it took 5 years for a task force that he led and is leading to implement some of their decisions. And Mr. Ilves is stressing that we feel that there is lots of time to implement new solutions, but actually the faster we do that, the better. Here is President Toomas Hendrik Ilves.
Good afternoon. I'm pleased to address the conference, Health in the Digital Society for Health, for it is, after all, a topic very close to my heart. 6.5 years ago, I was appointed by then Commissioner Neelie Kroes to head the EU Commission e-health task force, which was tasked to look at how information technology could be harnessed to develop healthcare in the EU. 5 years ago, this group of experts from across the Union presented a 30-odd page report titled Redesigning Health in Europe for 2020. When we gathered for the first time, the task force thought we would be dealing with the wonders of digital technology, how new digital technologies could be applied to improve the quality of healthcare. We realized almost immediately, however, that the true issues to tackle had nothing to do with any specific technology, but rather legal, policy, and regulatory issues regarding data, the new oil, to quote a recent article in the Financial Times. For example, the security and privacy of healthcare data, the transfer of data across borders, the use of clinical data in scientific research. These were the topics that were most salient to any kind of digital healthcare development. In the introduction to the report's finding, I wrote the following. Europe is aging. The proportion of the elderly in our countries is increasing, due both to fewer children as well as increased lifespans. How can we ensure that European healthcare in the future will be affordable, will not burden our economies, and at the same time keep up with the latest advances in medicine? Moreover, in a Europe of increasing mobility, how do we ensure that patients can be assured the highest quality of healthcare everywhere in the Union? We know that in healthcare we lag at least 10 years behind virtually every other area in the implementation of IT solutions. We know from a wide range of other services that information technology applications can radically revolutionize and improve the way we do things. We know as well from innovative approaches already used around the EU that many solutions to the impending crisis in healthcare already exist. In other words, by implementing IT solutions to preventative and ongoing healthcare, we can make life better for patients, indeed for all who require our healthcare services. The report outlines the task force's conclusions regarding the key issues faced by a fundamental reorganization of healthcare to make use of already existing information technologies. These solutions are often not medical at all, but rather deal with how in the future we will need to treat data, privacy, research, as well as the physician-patient relationship. Since not only EU citizens, but also their data move across borders, we require an EU approach where we harmonize our legislation so everyone can operate using the same rules. If we fail to do this, we can rest assured that other solutions will be found, either mutually incompatible national rules or private sector initiatives where our fundamental rights may not be guaranteed. The task we face is to ensure that in the future all EU citizens have access to a high level of health care anywhere in the Union and at a reasonable cost to our healthcare systems. To do so, we must make use of solutions offered by information technology already today. This ultimately is the fundamental conclusion of the task force's report, unquote. So that was written 5 years ago. And what has changed in that time since we presented this to the ministers of health in 2012? Not much, alas. Again, it is not for lack of technological advancement. In fact, 5 years since the report was presented represents more than 3 iterations of Moore's law, meaning that digital technology is 8 times more powerful than it was in 2012. And again, where the logjam is in our policies, laws, and regulations. Take something as simple as digital prescriptions, something enjoyed both in Estonia and by our neighbor Finland. Indeed, in Estonia, 98% of prescriptions are digital. Now, given there are 7 to 8 million visits by Finns to Estonia each year, what could be more logical than to make our systems interoperable? And indeed, I proposed this to Finnish President Sauli Niinistö some 5 years ago when that we do this, and in fact, President Niinistö agreed. The technological solution, hooking the systems up, given both countries use the same platform, X-Road, shouldn't have taken outside a week. Yet, the legal and regulatory hurdles involved have taken some 5 years to overcome, and next year, finally, a Finn visiting Estonia or an Estonian visiting Finland should be able to get a prescription from his home country filled in either country. Now, this is, again, an example of a technological solution that is easy to achieve, yet must go through an extended period of policy making, of harmonization, and then let us imagine we extend this throughout the EU. It is completely feasible to do this throughout the European Union today, technologically. But we need to do all of that work in the realms of legislation, in terms of regulation, before we can actually apply the technology which has already existed for a long, long time. Or let us think more broadly. Health records. Say I get sick in Greece. My medical records are in Estonia and in Estonian. Why can't a Greek doctor, who clearly can't be expected to know Estonian, be able to read my medical records in Greek and securely? This, again, is something completely feasible today, technologically, but in terms of regulation and legislation, we can't. Of course, we understand that people are worried about privacy and security. With all of the awful hacks that we have seen since our report came out 5 years ago, this is more than understandable. Yet, there have been no hacks of the Estonian X-Road system. Privacy has not been breached. And this is something that we need to keep in mind, that there are ways to actually transfer data across borders without having to worry about that issue, if we do the technology right. Moreover, today, and I'm glad people are more concerned about these things, the issue more and more is data integrity. And I would argue that data integrity is even more important than the privacy issue. For example, let's take blood types, just to be easy about it. If someone knows my blood type, I probably am not very thrilled about it, or if it is published somewhere. On the other hand, if someone changes the record of my blood type, this could be lethal. These are the kinds of issues that we have to address today already within our countries. In Estonia, all medical records are on blockchain, which means that that last problem, someone changing my medical data, is excluded. We need to have that kind of policy and that kind of technology throughout the EU. In conclusion, ladies and gentlemen, let's keep in mind, the most popular policy of the EU among citizens is the Schengen zone. That means we can travel across borders without the passport controls that stymied people from moving about for decades. I would say a second most popular policy is elimination of roaming charges, which again means that people can easily move from place to place in the European Union. Now, what can we glean from that? What can we conclude? Basically, I'd say that policies that visibly benefit average citizens are those that produce the greatest satisfaction with the EU. Not slogans, not the kind of utterances such as we need more of the EU, not less, but rather concrete policies that work across borders. By making policies cross-border, we can considerably increase the well-being of our citizens and make their lives easier, their medical care more convenient. So think about it. Let's hope it doesn't take another 5 years and yet another report to conclude what we need to do in order to, in the future, have easy, accessible medical care in the European Union. Meanwhile, I wish all of you a good conference, and I hope that your conclusions will drive the EU forward in making us all healthier and enjoying life throughout the European Union with fewer cares than today. Thank you.
Well, those were very inspiring greetings straight from California. I'm not sure whether the sun was shining there. It looked kind of like museumy, like, Well, I'm sure this message was very, very inspiring and good for us today. Next, I'm going to invite to the stage Kahil Ruana, the Deputy Director General of DG Connect from European Commission. And the aim of this directorate is to make digital innovations available to all sectors in order to enhance creativity, jobs, and competitiveness. Please, stage is yours. Thank you.
Good afternoon, everyone. I don't know many presidents who could speak about digital and healthcare as did President Elvis. It explains, what's happening in Estonia, and it's a real pleasure to be here, talk to you about digital for health. I'll try to answer some of the questions that were raised by President Elvis in my presentation. I try to be as quick as possible. he's right about the slowness, indeed, of the transformation that we would like to see in the health sector through digital innovations. And I don't need to preach you about how important is the digital transformation of healthcare, what it can bring in terms of improvement to our quality of healthcare, to the sustainability of our healthcare systems. The opportunities are huge, and they're ahead of us. And the issues are still there. I mean, the frustrations. I know we want things to progress, advance, but sometimes it takes time. And we would like, really, to progress this time even quicker than before. So the digital is today high on the policy agenda of the Union. In Estonia, it was high since some time ago. But I must say I've never seen it in the EU as high as it is today. Digital policies in general, the digital transformation of our economy and society, and the digital transformation of health and care. And in the revision of the digital single market, which is our flagship policy for digital economy and society, that was launched 2 years ago, 2.5 years ago. We did a revision in May 2017, a review of where we are, and we committed that time that we'll work on 3 pillars to ensure the wider integration of digital innovations, the better use of digital in health and care. And they focus on 3 issues that you see are in line with the questions raised and the challenges described by President Elvis. The citizens' secure access to end use of health data across border. So we talk about cross-border citizen access to end use of health data, and making sure that this health data is available and easily accessible for citizens, and easily accessible for citizens when they move across borders. Second one is about exploiting the potential of data, building health data infrastructure by aggregating data, anonymizing, aggregating data, and making sure that we can use that data to progress research, to make personalized medicine a reality. That also is a big challenge ahead of us. Today, there is a lot of health data that exists, we know, but the potential is huge, aggregating even more data, more precise data, more secure, and data that is checked and where no problem of integrity is there. And the third line of action is about empowering the citizen. And that's about giving the citizen the possibility to interact better with the health system, with more patient-centered care, with more feedback that a citizen can give about their health conditions, making their interaction with the health system easier, more fluid, etc. These are 3 lines of actions that we committed to work on even more than we did before. Of course, we were working on electronic health records and e-prescriptions in the past, and some of the achievements that President Elvis made as achievements that we did together. When we say we, means member states, Commission, and of course, all the health professionals across the health value chain. In order to check whether we were right in proposing this, we did a consultation in the EU, and we got a fairly sufficient number of responses from 35 countries, around 1,500 responses, 30% of which from organizations representing all organizations in the health sector, almost in Europe, which makes this consultation very significant in our view. And if you look at what came out of it, regarding the citizens should be able to manage their own health data, that access issue, our first pillar, you see that more than 90% of the respondents said that this should be the case. If you look at sharing of health data, and making that data available for exploitation, which was what we're proposing for the second pillar to a large extent. You see, the more 80% of the respondents say this is something that could be beneficial for prevention of diseases, for integrated care, etc. If you look at the need to upgrade our infrastructure for data handling, our infrastructure for computing, our tools to make the best out of the data, to pool data and make the best out of the data, you see there as well that they're close to 70% of the respondents said this is something that is useful and we need to do. And if you look at the current situation of our citizens and when we ask them, do you currently have access to digital health services? You see there that for more than 50%, they never had any interaction online or any access of a digital health service. More than 50%. It's not the case in Estonia, obviously, which is, much more than that, more than 95%. Please indicate to what extent you agree with the following statement. Patient feedback to healthcare, this is our third pillar. Is it useful or not? And there you look at between those that agree and that strongly agree, you are also more than 80% think that patient safety and a more fluid interaction between the patient and the health professionals could be very useful. This gives us an indication of, the preparedness of our society and preparedness of the citizens to engage into a more ambitious digital transformation of our health and care. And if you look at the hurdles that came out as, the blocking factors for this upgrade of our digital healthcare, the first thing comes is indeed the security and safety issue. You could see them in many forms here: privacy, security. Indeed, our citizens and professionals are afraid of cyber attacks. They are concerned with cybersecurity. They're concerned with their privacy breaches. That comes first, but comes also the issue of interoperability and the possibility to have interaction between the different digital health systems in order to get cross-border access, in order to do the aggregation of data, and to ensure a fluid interaction between the patients and the health professionals. So if I summarize them, the security, safety comes first, interoperability, exchanges come second, and you could see them in the various breaches and the various statistics over there. That confirms what we proposed, and we all together, because that was based on consultation we've done with all our stakeholders. And when we say we, in the Commission means DG Sante, DG Connect, the rest of the Commission dealing with these files as well. We're proposing to move on these, and I would just give you hints on the tracks in order to address these three pillars. And Commissioner Andriukaitis will tell you about them more tomorrow, and you'll be following them in the various panels. Very quickly, on the cross-border access to health, to health data. We've been investing in this field since a long time, and it was indeed one of the main recommendations of the task force established 5 years. Investing on using all the instruments that we have policy making, the regulatory frameworks, using also financial means to test, experiment, introduce the technology, but also using the third pillar of policy instruments, which is coordination, awareness raising, mobilizing of the stakeholders like we're doing all together today. And we've been working on ensuring interoperability of electronic health records, availability of electronic health records for all citizens, very important, and interoperability across borders. I think a lot has been achieved. We have today standards on patient summary. It has progressed, and we have now, I think, 16 member states engaged with the Commission in making adopting these standards and making them work across Europe, cross-border. The same thing on e-prescription. We progressed. This is very good step forward, and we know that more member states are coming in and joining in. We're supporting this financially and the Connecting Europe facility and the digital service infrastructure in order to make sure that we move to deployment. We worked initially on piloting, testing. If I remember the first project we launched in this area, that was in 2008 or 2009 to experiment. It took us 10 years to get now, hopefully, to full deployment of just the patient summary and e-prescription. I think we should be much more ambitious now and go to wider than this. And this is our next steps. And we're ready, really, to engage financially. We're ready to engage in legislation if need be. But I do think we have a good legislative framework. But if need be, we're ready to go more than this. We want to have full electronic health record accessible all across Europe, accessible by every citizen in the Union. This is our ambition. We want also to build the infrastructure that will help us aggregate this data, use it, exploit it. And we also announced that we will be working on interoperability. We'll be working also on the free flow of data to make that data move across Europe. Estonia, big supporter of free flow data, so that data can be localized anywhere in the Union, eliminate exceptions, including for health. And we're working on connectivity. We launched a big initiative on the Gigabit Society to ensure that we have the connection infrastructure that will enable us to use the data, and on high-performance computing on the cloud to make our researchers, our scientists, our doctors, give them the maximum of computing facility, maximum of tools to be able to exploit that data. We're working on all this. And we have announced ambitious initiatives in the sector. On high-performance computing, we're putting €1 billion in the next 3 years to build this infrastructure across Europe with big application in the health sector. The first application for the computing infrastructure, the first applications include, among the 3 first ones, health is one of them. So that's the infrastructure. That's the aggregation of data, possibilities to do so, and the tools that we can give to our scientists, to our doctors, and to health professionals to exploit that data. We're also continuing to work on research and innovation to make sure that we get the latest technology in Europe, and we get industry in Europe that provides this technology, and we get that technology applied in our health system. Our investments in the current multi-annual financial framework in digital for health is around €1 billion dedicated for digital for health, and we have around another €1 billion that goes into big data, that goes into all the components that we need for the health sector, that goes into robotics for health. All these are technologies in the preparation and ready to be deployed in our health system. So that was, in short, what we're trying to do to address the 3 pillars that I mentioned. And we hope that we'll be announcing by the end of the year now a comprehensive strategy, go more into the details of this. I just wanted to give you a snapshot of what is being prepared. And please tell us if it's the right way to go. If it's not the right way to go, I hope that you will be discussing some of these issues in your 2 days here. And thank you very much.
Thank you very much for this presentation. As well, our 2 speakers mentioned, the process is going on in Europe, the process of going into digital world, but it's going on pretty slow. There are hurdles in the legislation we have to overcome, but also the question always remains, who will finance it? Where is the money? And that's the topic of our next panel that will be led by digital expert Mr. Paul Timmers, who will take the stage now and will lead this conversation for next 45 minutes, please.
Thank you very much, Neem. So may I also ask my panelists to join the stage, Felicitas Riedel, Brian O'Connor, and Eva-Jan Valenten. And we will start this session right away, so appreciate that you stay here. Perhaps you take the seat, yeah? Eva-Jan. My name is Paul Timmers, and I'm going to moderate this session about where is the money. I'm a former European Commission official, but everything that I say here cannot be used in favor or against the European Commission. It's my personal opinion. I hope you will engage during this session. It's actually the intention that you also pose your questions about where is the money. And I know that about half of you, at least half of you here, are in some way or another directly involved in health innovation, health and aging innovation, either as a researcher, perhaps as a practitioner, perhaps as a company. So don't hesitate, because here you've got a number of experts. Well, who do we have at the table here? We have Felicitas Riedel, who is the head of the Life Sciences Division at the European Investment Bank in Luxembourg. She's responsible for life sciences, pharmaceutical and health sectors, and has also been working in the European Investment Fund. Then we have Evert-Jan van Lente, who is the Director for EU Affairs at AOK Bundesverband in Germany. And AOK is one of the largest, the group of AOKs, as a matter of fact, is one of the largest insurers in health in Germany, insuring 25 million persons. He's working in Berlin and in Brussels. A true European, isn't it? And really a true European, I think, is also Brian, who I don't need to really introduce, Brian O'Connor, the head of the ECH Alliance, but in this context, also very importantly, that Brian is very much an entrepreneur himself. He has set up several companies in the healthcare and health services area, and so he can also speak from personal experience. So this session is about where is the money. Now, I've just to be sure been looking up, what is it that people are actually expecting about this whole area. And indeed, if you look up one of the gurus of the internet, Mary Meeker, who has literally a 300-slide presentation about what is happening in the internet world, she says, with 30 slides about the area of health innovation, this year is the digital inflection point for health and innovation. And why? Because she sees this whole flow of data. And if you look up the reports of, for example, McKinsey, they say, likewise, European healthcare is the golden opportunity for private equity. So again, very positive. And underpinning all of this is, of course, amongst others, the aging of the population in Europe and in many other places in the world. But we have been saying this for 10 years, isn't it? That is the golden opportunity. So there are all these kind of barriers, like the complexity of the system, like the difficulty that is public and private financing, like perhaps the hesitation of doctors, or perhaps even data protection. Who knows? There are all kind of things. So let me start off with the panel. Perhaps we start at the side of Brian. Brian, let's make this concrete and give us a case where you know about investment in health innovation. How did they find the money? Or perhaps you imagine something where people can, that is still a case to come. How do you find the money? What are the problems that you are running into? And if you are here, what is actually the benefit of being here, the network of people here?
Okay, so a couple of thoughts. First of all, I'm glad the title is simple. Where's the money? I remember when we first planned this session, there were 5 sentences describing what we were about to do. And I hate things that take so long. So the key question is, we have all agreed that by the time we finish this session, with your help, we're going to answer the question. So those of you who need money can line up in the winners' chairs over here, and the rest of you who don't need it can stand over there as well and give it to us who do need it. My experience comes from my own business background. I've had 32 startups over the years. I know I don't look 120, but I feel at 120. But in that time, I have experienced all sorts of disappointments when I go along thinking I've got the best idea in the world. And then over a period of time, I realize, of course, that everybody that tells you, I always ask a couple of questions. Who are you and what do you do? And almost always the answer is, then the third question is, who else is doing this? And almost always the answer is no one. Now, I don't know about you, but I have never found anything that is unique. I've always convinced that someone else is doing it. So that's part of the problem for investors or financiers, for companies and entrepreneurs, first of all. There is this obsession almost, which is fundamental to being an entrepreneur, by the way. You really must believe Otherwise, no one else will believe. But you've got to be realistic and have a broader view. What I'm more interested in today is giving you an example of, through our what we call our ecosystem network, about 120 meetings a year, each of them at local level. So we drill down to the grassroots. We know what's going on in the real communities. And the conclusions are as follows. Everywhere there appears to be a shortage of funding from the traditional sources, whereas the NHS in the UK or many of the other health systems. That is the way it is. People get depressed and work on shrinking budgets, which means that patient safety suffers, as we've seen. It means that entrepreneurs have even more difficulty getting into a system because they don't have the evidence to convince the procurers that their system will bring savings and better safety. What I do find is that everyone turns automatically these days in these many regions to the Commission. Rightly so in many cases, to Horizon 2020, for example, which we all know has become a very competitive instrument, therefore a very good instrument. I'm glad to see the stronger emphasis, however, in giving out that money on, are you going to do something real with it? So this is not only about research, it's about, please tell me what the benefit will be to citizens, real citizens. And I think much money has gone into research in the past and much of it was well spent, but quite a bit of it was not that well spent, in that many researchers, and I know some of you are in the room, and I've got a special escape route out here not to meet you afterwards, and that is this. One chap in Copenhagen said to me one day, what have you got against researchers? I've published 637 papers. How many have you published? And I said, none. And he said, so that's the answer. And I thought, I said, why are you so defensive? Why don't you tell me one of those papers that resulted in a better healthcare or care for a single person? You don't understand researchers. So my conclusion is, many people out there do great work, but are depressed by the complications. They know Horizon 2020 is great, and they bid for it. We help them do that. But there are other funding streams out there that I genuinely feel they don't know about. We worked recently with a region, which I shouldn't name because we're still in the middle of it, where we introduced them to the whole idea of the broader range of funds, whether it's through Regio, whether it's through GROW, whether it's through all of these others. And we in the health sector are too focused sometimes on Horizon 2020 only, when in fact there are many other instruments. In terms of other funding, we have managed to create and identify at local level lots of programs which nobody seems to know much about. And I find that there's money everywhere. One example in a particular country, and you'll tell where it is from my accent, I hope, because I've tried to retain my Belfast accent, even though I left there 42 years ago. And there is a particular tool which may exist in your regions called the Collaborative Network Program. It is to bring together all the players on a particular topic in that region, identify then the obstacles and break them down, and then move forward to solutions and economic, very important, economic help. Who runs that program? It's not the health department. It's the Department of the Economy, because people forget often. They look at health as a cost. Reality is that health is one of the biggest engines for economic growth in the world. And what do we all do? What do people in the health sector say? Oh, haven't got enough in my budget. Well, why don't you go and use somebody else's budget, like the Department of the Economy? If you create jobs, you're helping them. So just to finish, Paul, I would say is that it's very important that at the end of this meeting today, and I know there are some people on the panel who have got lots of money. They're going to tell you about it in a moment when I shut up. What I'm saying is you've got to broaden your view of what you mean about funding. Don't be constrained by what you've done up to now. Try to have a broader view and seek advice from those who know where the money is.
Brian, later if we have time, we may also come back to your experiences with, for example, private funding, private equity, or those kind of things. But let's first move to Felicitas and also briefly explain to the audience what the EIB is. It's that big beast over there, isn't it? Tell us a little bit about what you see as actual investment and investment cases.
So first of all, thank you very much for being here. My biggest aim for today is to make you all aware of what EIB can do for you. So first of all, we are a bank, and we try to support through our lending activities key priorities that are set out by the EU. One of them that is relevant for you is infrastructure, but also knowledge economy. Both have an important say with regards to health. So EIB is not only supporting the hospital infrastructure or any digital infrastructure, but is also supporting health from the view of supporting innovative companies, innovative approaches, innovative medical devices, but also clinical trials that are conducted in Europe. So what I want to say is we can support bricks, infrastructure, but also intangible assets. And therefore, our lending spectrum in the areas that I assume are most concerned for you can reach from 500 million to billion for a major hospital projects in your country, but also can be the startup company that we recently did in Finland, which is a case I would like to bring to your attention. It is a company called New Icon that is producing robots for hospital pharmacies and also for compounding, which is very relevant in cancer treatments. So therefore, we provided them an 8 million loan, which what you probably have heard so far from EIB sounds very little, and it's considered as a quasi-equity investment. So even though the company was still at very early stages, we were able to provide them a loan, and the repayment mechanism we structured in a way that is meeting the demands of the company. So we are also relatively innovative and flexible in the way we structure it. You still have to bear in mind we are a bank, so what the financial means that we can bring to you needs to be repaid at a certain point. However, in terms of the risk appetite, that also with the new mandates that were proposed through FC and also InnoFin have increased. So therefore, if you are in doubt, if the project you are having in mind is of relevance for us, please do not hesitate to contact us. There are certain minimum thresholds for us to look into, so we need to justify our investment, meaning other than a traditional bank, in order to make sure that the projects that you have in mind are in line with EU objectives. We need to define a project that is considered worthwhile to obtain the EU funding. Once this is in place, we can discuss the financials around it. And I think this is, for the moment, the key message I wanted to bring to you.
So here you already have a concrete contact point, although 8 million is a lot of money. So there are, of course, also companies that are perhaps they need 500,000 or 1 million or 2 million. So perhaps also talk a little bit about that.
I was just going to say, if you have a 500 million health infrastructure project, then a large infrastructure, then the 8 million for an early stage company, which is not yet bankable or still considers equity risk, is also something that most people would not automatically link with EIB.
No, but still possible.
Yeah.
Eva-Jan, I think very interesting that an insurance company, a health insurance company, is also taking investment in health innovation seriously. Tell us a little bit about what your Bundesverband does and how you look at health innovation investment, and perhaps with a concrete case.
Yeah, thank you. Thank you for the invitation being here. First of all, I would like to say that we should be aware that there is a lot of money in the system. Germany spends 220 billion euros every year in the health sector. And basically, by digitalization, we want to be more effective and more efficient. So basically, the money is there and we want to be more efficient. The problem is, the big challenge is that this means, of course, that there must be a reallocation of financial means. And this is not a simple case. And therefore, we are working on several levels as AOK organization. As you already heard, of course, there is a lot happening on digitalization in hospitals or in also social health insurance itself. But I think the real big challenge is coming if we are talking about communication between doctors and hospitals, doctors and patients. And therefore, we need definitely a digital health infrastructure. Without digital health infrastructure, we will not be successful. And we as AOK organization are very much frustrated that we have been working 15 years on the national level to try to implement this digital platform, and we did not achieve much. This 15 years only spoiled a lot of money, billions of euros even. And therefore, last week, my organization made a press conference, and we launched, together with several hospital organizations, doctor organizations, and a software company, a new initiative to make digital platforms, first of all on the regional level, but of course we want to integrate it afterwards also on the national level and also on the EU level, but it's 2 steps further. So this is something we are working on now. This is, I think, the basis for a lot of applications, what we need. But there are also a lot of other things we are working on. I would like to mention maybe 2 concrete examples. One example we are more and more investing in is patient coaching, especially for patients with chronic diseases. And the business case for us as health insurance is mostly that we can avoid hospitalization by a better coaching, continuous coaching of patients. So I think the coaching issue will be also a growing issue for digital applications. And the third example I would like to mention is that we are now rolling out a pilot we had in Westphalia, North Rhine-Westphalia, and we were there working in a nursing home and making diagnostics and teleconsultations for the patients in the nursing homes. And it turned out that we can be much more effective. Many patients didn't go to the right time to the doctor, or they did go to the doctor without any serious problems, and this could be done by telemedicine. And we are very much convinced of this concept, and when it is working in North Rhine-Westphalia, we also want to roll it out all over Germany.
And just to clarify, the ideas for innovation, they don't need to come from your own organization, AOK, but they can come from hospitals, professionals, individual entrepreneurs. How is that?
Yes, in fact, we in the Bundesverband also have a center for innovation, but most of the ideas come from outside. Doctors, hospitals, but also companies are coming to us and asking if it is feasible to make some new projects.
And do
so
you go
on
for
both sides?
Do you go for smaller or only very big investments?
It depends, of course, what kind of business case is behind it. If there is a business case in avoiding hospitalization, it is rather easy. We have also, of course, such projects which empowers patients, for instance, with more information, with preventive measures, and so on and so on. Very good. But this is difficult to make a business case out of it. And we say there's also a responsibility of the citizens themselves, and it is more or less a shared responsibility. We want to encourage them to have a more healthy lifestyle, but we cannot pay for everything. So this is also an individual responsibility of the citizens.
All right. So be prepared that you also, in a minute, ask these people what they can do for you or the problems that you are running into. But let's go a little bit to the barriers, because perhaps there is a lot of money around, but still there are also serious barriers. I mean, Eva-Jan, you are mentioning already something. And it can be perhaps, I don't know, it could be that there is not enough flow of innovative ideas, that there's a lot happening in these research programs and it's all shelved. You know, there are not enough startups. Or perhaps the startups in Europe are great, but they simply never go out of their local environment and they don't become European. You're suggesting that some of the stuff should become European, but does it actually? Or perhaps it's the business case, or perhaps other issues. Felicitas, what kind of issues do you run into that you think are really barriers for investment?
I think there's one barrier that is important to tackle, is the ownership of the data. So is it at one point the patient who owns the data? Is it the payer or the insurance company that owns the data? Is it the government, the public entity that pays, for example, if you have a universal healthcare access? So that needs to be clarified. Then I think the data protection is something that often hinders, or the legislative package that allows somebody to use the data. So what we have seen from our perspective is that in countries such as Estonia or also Malta that has adapted the legislation, we saw a booming startup culture all of a sudden in the area of digitalization, while all of a sudden the data, aggregate data, was made available to companies to use it for a certain analysis or to come up with novel preventive ideas linking certain diseases, which in other countries are not yet possible. This is in line with the fact, if you want to have even a national strategy, but then you want to link different hospitals, you don't have a common ownership of hospitals. In some ways it's the municipality, in some ways it's the government, sometimes it's even the army. So, or in others you have the former train union owning hospitals. So you have different structures, or be it just privately run, publicly run. So this needs to be clarified. And therefore you have also a legacy that you need to address. So I think there are several ways to tackle.
And you as a bank, are you willing, perhaps in a generic form, to share some of that experience amongst the various people that are coming to you for investment so that they can learn from each other?
I think, of course, the beauty that we have at the EIB is that we have a sector overview. So we can share best practices where we see what has worked well in certain countries, certain regions, that may work in the other country as well. While I want to put the caveat, there's not one solution that works everywhere. Every situation is unique. However, what we do is our financing, we have to ensure that the projects we support are technically, economically, and financially sound. So therefore, we do look into it, and we are also able to provide in certain circumstances technical assistance, which can help to shape projects and ideas in order to maybe provide the final twist to create something sustainable.
So it's not just knocking on the door, there's a really serious process including this technical assistance. Brian, what do you see if you would have to mention one or two kind of perhaps showstoppers or things that are really significant hurdles?
Well, I think some of them are being overcome. I mean, first you need some intelligence. You need to understand what's actually happening on the ground, as opposed to the many myths that seem to hold us all back. I still find it hard to believe that this is the one sector, I think, left in the world that has failed to move on at the speed that many other sectors have. Now, that's a criticism of me, but it's also a criticism of others, some of you maybe included. The reality is that what we find from these ecosystems we have, these multi-stakeholder organizations, is they feed up to us their top 3 priorities. And often what happens is they tell you about an issue they've got, and someone else on the same phone call says, but look, we did that 3 years ago. And sometimes it really is as simple as saying, you're not on your own, many others have the same issue, and these people tried this and it worked, or, and this is important, these people tried this and it failed, because we should be open and honest enough to learn from failure. So, an example. Within our network, we find all these priorities coming up. So we have this intelligence coming up from many places in Europe. And it's dynamic, it's very up to date. And we say to them, what are your biggest problems? One of them was the question of medicines adherence. We all know this is a problem throughout the world where people either forget or refuse to take their medication. That inevitably leads to them going to the hospital. It inevitably leads to them taking up beds in hospital, operations being postponed. All sorts of issues arising from that, not least the safety of the patient and the worry of the family. In Northern Ireland, they decided to tackle this as a problem because though it wasn't in monetary terms by some of your standards budgets a big amount, it was 112 million UK pounds a year extra that this was costing the health service. So we want to drill down and get a particular example. As a result then of the government deciding to invest in solutions, and the government admitted this, and some other governments may not admit this, but it's very honest. They had money to buy solutions. The problem was that the people who were going to do the procurement did not know what solutions were out there. Because if you're sitting in a procurement department, first of all, you always feel you're under siege. Secondly, you don't have time to understand what's going on. And in this case, the average time from thought to procurement was going to be 3 years. even I can multiply 3 times 112. And the minister said, I can't afford to lose that amount of money. We've got to do it more quickly. By introducing a new form of pre-commercial procurement, we reduced that procurement time to 6 months. With the result, and we didn't finish there. When that was working in Northern Ireland, we took it on a roadshow around our ecosystems. And people said, oh, we have the same problem, except it's much bigger in our region. So I think there are actually quite simple human things you can do by sharing not just best practice, which is important, but real live examples of successes and failures. Yeah. And where did the money come from that? It came actually partly from the Department of Health and partly from the Department of the Economy again. Why? Because the winners created companies and created jobs, which then became export companies as well. Yeah. So there's a virtual circle here, which if we could just join the health and economy budgets together, we can create more jobs, which is what Europe needs.
That's interesting as a policy statement. And of course also what you just say, the sharing, that's the role of this event here for sure too. Eva-Jan, what are some of these barriers that people are running into?
Yes, I would like to mention 2 things which are interrelated. I think one thing is that it's also mentioned, I think, in the digital health resolution, which should be decided upon tomorrow. I think it is about a payment system which is mostly based on fee-for-service, the fee-for-service principle. And therefore, we in Germany, we try to define all new digital services, try to find out how much may it costs, and then we have an additional service. This lasts probably 2 or 3 years to get the one new digital service into our catalog, and therefore we should try to find out other ways of payment. There are internationally several possibilities. We also try to make some pilots on bundled payment where we pay for a certain pathway of patients, which mostly includes hospital and outpatient care, and then it is no matter for the lump sum that we are paying if this is done on a digital way or on another way. So then it is up to the providers to find the best way. So,
but that's some of the stuff that you could actually do, isn't it? Because you can change the reimbursement system. You can say I do pay per performance and not pay per service, per action.
Oh, it would be nice if if that would be the case. We can make pilots and try things, but basically the reimbursement system is in our legal system. So this needs a change in our law, and therefore we need political help to change this. And I mentioned the bundled payment, but it's also, of course, if you're talking about outcome-based payments, this is also something which we should discuss, I think, in the future. And these are issues which might help shifting also the financial means in new directions, and therefore deploying the potential of digital systems. But I also wanted to mention a quite an associated thing, but which is also for me always striking. If we have a pilot with a new innovative program, we have mostly very motivated doctors and motivated hospitals and motivated people who are doing this. If we are trying to bring this all over the country, we find out many doctors are not motivated to work in this way, and we are, in the end, we are very much we are disappointed about the results we have in this project, and this meaning again that we should focus on motivation, and we should also motivate the doctors and hospitals to do the right things.
There you mentioned probably something quite important, that you need to involve those that will be concerned in some way or another, including the medical professionals at an early stage. It's a very interesting article by the CEO of the Cleveland Clinic, who describes that if you want to introduce health innovation, of course it has to deliver real benefits for the patients or for the citizens, but it also has to deliver benefits for the health professionals, so self-interest, properly informed. And by the way, he also remarks that if you do health innovation, it needs to be, as he called it, embrace tradition, which I think is a tough thing for people that are in innovation, because they want to disrupt rather than embrace the past. So over to you. Who has got a question for the panel here, or who wants to share perhaps a personal experience? I see a hand over there. Yeah, please go ahead. Over there, you have a microphone. There's a person. Yeah.
I have a microphone now. Just a quick one. How do you think GDPR is going to affect the investments?
GDPR. Let's do a very quick round.
I think I look at everything as an opportunity. So whatever it may be, whatever crisis there is in the world, there's always an opportunity. And as some of you know, I spent quite a lot of time living in Hong Kong and China for 12 years. And there they have the Weijie terminology, which is only one word. And it means both crisis and opportunity. The Chinese always have a saying, which, you know, an old Chinese saying, even if they only just made it up today, just like the Irish. I think the opportunity there is this. There is a huge opportunity, not only in consulting and helping companies and governments to be ready for this, but there's a huge opportunity for entrepreneurs to make sure that the tools that will enable the government, to fulfill their duties and responsibilities as citizens, which fundamentally change, there's a huge opportunity there. And I know of many companies already creating new products, new services, new tools. So
based on data protection, yeah.
But I mean, you know, data protection is something really crucially important.
And security will be likewise, of course.
But it's often used as an excuse for doing nothing, if I may say so.
I think, I must say also, I was quite a while ago when we had the eHealth stakeholder groups, I was impressed actually by the professionalism of the participants there who said, data protection is a given. We are going to investigate how we are going to make use of it. We just take it seriously. So it's not going to go away. It's there. I think you see it also. But people find ways not to have it as a showstopper, even if it is not trivial. That's, I think, what you said, Felicitas, isn't it?
Yeah.
Yeah. You can work with it.
I think so.
But perhaps you have to ask their experiences specifically. We've had a question over there. Yeah, please go ahead.
I'm going to introduce myself. I'm Tony Dadeu. I'm the director of the Agency for Health Quality and Assessment of the Ministry of Health, Catalonia. And we are responsible for the public procurement of innovation as well. And one of the things is when we ask and we are involved in the innovative procurement is about the needs, thinking about the needs and thinking about the outcomes. But this is not my question. The question is, we agreed that there is enough money, there is the right time and the right information to know where the money is. So this is not my question. We've raised some barriers here, and there is a barrier that being involved in the procurement process and dealing with policymakers, the big thing, as I found myself, is there is an aversion of risk. Aversion of risk of whom? From the policymakers, from the commissioners, and then as well from the entrepreneurs. So they don't want to assume risk. And this is a big challenge for us. So I think it's a party that there are many parties playing around. First of all, and I must say, I'm very conscious about the governments. They are very reluctant to take part in assuming risk of new procurement formulas. So we have to push, and this is we are starting the journey. So we need successful stories. And this is something that I don't know from your side if this is something that you've come across. So getting successful stories from pre-commercial procurement and public procurement of innovation.
That show that you can
then
take a
you
risk.
can convince the policymakers, the payers, to play in this role.
Yeah.
Thank you very
Let's
much.
see, I mean, of course, also risk can be a reason to invest, because the return on investment can be larger. How do you look at risk? I mean, EIB doesn't have the reputation that it is the biggest risk taker.
I mean, first of all, I think as EIB group as a total, as that also includes the ERF, we basically support a company during its entire lifetime, from its foundation to our ERF daughter that is providing business angel networks with the right funding. It's the largest fund-of-fund investors, so the equity comes through ERF to the startup companies. But then what we noticed in our experience, and that's why EIB came across with the new financial instruments, was that maybe it was okay for companies to access money early on, so the first maybe 50,000, 100,000 euros to develop an idea, but then when it came to the financial needs of 1 million, 2 million, that was already a first hurdle point. Yeah. But then even if that was done and then you had some clinical trials to conduct, that's when you need massive amounts of capital, you're still at a very high risk. And then for a startup VC fund, the life science model does not really work. So if you have a fund life of 10 years, and then you look in the life science sector where it takes maybe 15 years to bring a product from inception until it's a final approved product that went through EMA and FDA approval, you cannot do this. So therefore, there's a risk reward that is difficult, and that's where the US just has far more financial power. They have more business angels with deeper pockets than Europe has, and they also have more venture debt available to also address the second valley of death. Now, EIB has also tried to tackle, as we came from the large corporate investments, large infrastructure investments, we also try to expand, increasing our risk appetite. And that's why I said, also with the Juncker plan and with the Innofin products, we could take quasi-equity risk. So we could help companies that were at the pre-commercialization, or they have had a pilot production ready to scale up to industrial production, which is very capital intensive. It is still difficult for commercial banks to really address it yet, because maybe you were not yet cash flow positive, but it was clear that within a 3-year time horizon, you would be making quite some significant money. And that was something that we felt now able to assess the type of risk, and that we felt...
So you're also getting more into this risk assessment. Eva-Jan, for that matter, do you think that working in partnerships helps to reduce risk? So you bring expertise together?
Yes, I think sure. This is what we also are doing. Talking about risk, we have more or less a different approach to risk, a different dimension of risk. Maybe also the person who was posing the question was referring to. We have more or less the politicians who are risk averse and don't want to have problems with the physician organizations, hospital organizations. We have the hospitals who are risk averse, who don't want to invest in new digital investment. We have the doctors who don't want to change anything because they want to keep things as they are, at least, who only want to have additional money, thus not getting efficiency gains in the end. And the third is the social health insurance, are exactly also risk averse, because they are afraid that we will only be paying extra, and it is getting more and more expensive, the system, and we will not realize any efficiency gains. So you see, this is more or less the risk aversiveness, which is also one of the problems which was hindering our digital health platform in Germany.
Indeed. So here you may find a number of politicians that are not risk averse, and policymakers. There was a question in the back. Yeah, can you state it briefly?
Yeah. Marc-Lange, Etel. When we look at the landscape in Europe, we see that the member states who have a centralized healthcare system or a beverage healthcare system are much more performing in terms of innovation when we compare them with the Bismarckian healthcare systems. Is there a relationship? I would like to hear the panel on that.
Let's not make it theoretical, but indeed, does it help if you have a more centralized approach? That's perhaps a difficult one.
What do you mean centralized? What do you mean centralized?
Well, you say a more centrally organized healthcare system, eh?
I think it comes back to the point I previously made. At least the ownership of the data is
that
very
is
clear, and you have one decision-making entity, so it's easier to impose and to introduce.
So there will be important discussions here around ownership of data platforms, and those kind of things. Perhaps that can help to bring that kind of common opinion that people can support. Question over there.
Yes.
Shout it.
Hello?
Yeah.
Works. Yeah. I'm Tavi from Nortal, from Estonia. And many healthcare payers, they operate in a kind of annual budget cycles. We see that at least the ex-head of Estonian Health Insurance Fund was here. So in Estonia, it has to be a balanced budget every year. Would EIB, for example, be willing to invest into projects where, let's say, if there's a digital program, for example, for diabetes management, which of course has a cost right now, and then hopefully will bring benefits later on, to kind of work together with those type of payers to create this or balance off the payments.
It's clear, yeah.
I mean, of course, I cannot give a yes or no just from sitting here, but clearly that would be something we could look in. And that's, I think, the beauty from an EIB financing, as we can provide long loan tenors. So we can also reduce the financial burden on the borrowers. So we can see what would be your income look like, and what kind of loan or debt can you digest, and what would be a right repayment scheme. But in generally, that could be something we could look into.
We also, I would like to mention, this is a problem, of course. We try to overcome it sometimes by making 5-year contracts and calculating it on a longer basis, but it is difficult for us, and therefore we had, for instance, in Lower Saxony an interesting project on schizophrenia, and this was more or less pre-financed by industry, and it was a PPP in the end, and therefore we made a risk-sharing model, and this is also a way that capital givers can invest in such a project, and we are allowed to get the benefits over the years and not investing in 1 year, which is a problem for us.
And I guess, Brian, that is perhaps also your experience, even with private capital, that they are willing to wait 3 to 5 years before they see the exit.
Yeah, and I think the thing that hasn't been touched on here is the power of the consumer. Because in every other sector, the consumer dictates. We dictate how banks work. We dictate, not all banks, of course, not EIB, but we dictate generally where we want our service, when we want our service, how we want our service. How many of us bother going to a bank anymore, right? So what I would say is we have not moved far enough. So one of the financing instruments is actually the public. Example, in the UK, some of you will know of a company called Babylon, which set up this virtual visit system. NHS said it'll never work. We tried that, it didn't work. Why did it not work, with all due respect to NHS people here? Because it was the NHS that tried to do it. Because the NHS were taking their traditional approach and trying to move it into what they think is an incredibly innovative idea, i.e. talking to your doctor, on your iPad. So what I'm saying is you need innovative entrepreneurial people. They've just raised another £60 million. People said you'll never get the doctors, there's a shortage of doctors. They're getting more and more doctors every day. Where are they getting them from? The NHS. So don't underestimate the power of the consumer pound. Get out there and get a subscription model. Link it to an insurance company, and you'll make a lot of money.
So that's a smart model. And as a matter of fact, that company is going for a next round of investment.
That's right.
We have just a few more minutes. So we take one short question, short answer. The lady here.
Thank you so much. I'm Ruth Amos, and I actually moderated a digital health panel on this very stage back in May. And it was in front of an audience that was very high tech, but wasn't really in healthcare at that point. They had a lot of very innovative ideas, but we asked, one of the panelists was from EIT actually, which is part of Horizon 2020. And we asked the audience, do you know what this is? And one or two people maybe out of the whole audience knew. So my question is, what, if any, efforts are being made by companies that do funding for healthcare IT to reach out to people who are very technologically have expertise, but maybe not have waded into healthcare?
So what is the bridging that is happening? Correct. I think this conference, that's perhaps a real ECH Alliance question, isn't it?
It is. And well, to give you an example, we always try in our events to try to find someone who's not in healthcare. And so, for example, we've had McLaren Formula One team, who surprised me by telling me that they actually provide the platform for for any of you who've been delayed at Heathrow because of air traffic control, blame it on McLaren, because they actually supply the platform for that. They then took all their knowledge of sensors and reading of sensors and come into the pits for tires or don't come into the pits and all that, and now are applying in a big way in healthcare. So we really do encourage you to think. Stop thinking of the people who are in healthcare. You're taking your point. Get outside of it. Think of the people who are not yet in it. And you've only got to look. How many people would disagree that the names that are in healthcare now, many of them will not be here in 5 years' time? You've only got to look at the Googles, the Apples, the Amazon. It's just, it is the reality of the world. What are they driven by mainly? Consumers.
So perhaps also you may want to talk actually also to the people in the European Commission who have a long-standing collaboration between the health department and the IT policy, the digital policy department, and it's a profound one. And I think it has been productive. So it's not happening only in the business world. Let me go finally to the panel. So you've got a few seconds to get the answer. So you are expected to take a lot of action, but let's give them an action. Which action would you take following this panel and answering the question, where is the money? Which action would you take home?
I'd like anybody in regional governments or member states who are desperately keen to bring in digital health infrastructure and are short a couple of $100 million on their budget. If they could get that somewhere else, they could convince their minister to go ahead. Many projects are killed off because there's just not enough in the national budget. You should talk to me, because there are solutions to these things, and many of them, one of them sitting on the stage, and there are other people here who can help as well. But let's get something big happening to give the example to others. Let's not keep worrying about the 100,000s.
So don't let them off the hook. Eva-Jan, what is the concrete action that you would say, this is what I can do?
I think we should start also in AOK to try to bridge the gap between the technicians and the payer organization, social health insurance as payer organization. And I think we should more formalize and make a real platform that we can talk with technicians what possibilities there are in the regulatory framework in Germany, and that they can give us their ideas which might also be successful for our projects.
And you are willing to take that action within your organization to push that. Great. Felicitas, last word.
So where's the money? I think, first of all, we have to unlock the potential savings through e-health. I think if we invest clever in this, we can reduce the healthcare spending. Second, I think EIB is willing to support, as I mentioned before, sustainable projects in this sector, so please come forward. But also I want to make you aware that EIB has quite an intensive technical assistance project where we can, if you are a government, I think we have also the Romanian health minister here, so we're doing a big TA project as well in Romania to help them implement 3 regional hospitals. But also we do financial advisory where we can help startup companies to try to get ready to access funding sources.
Very concrete. Thank you very much. Let's give a big hand to the panel. Neem, I hand over to you.
Thank you very much. Thank you.
It was a pleasure.
Thank you. Thank you. You agree?
And our day is not over. We will continue again in 3 sections. And we will introduce the sections. In the engine hall here, there will be a section on M-Health. What kind of apps and what kind of digital therapy prescriptions are there for us to use. So who's interested, please stay here.
And downstairs in the power station, there will be a session on virtual reality, a new way to train and treat. That would be my choice, actually.
And during our conference, we have also innovation showcase sessions. Today is the first one. These are the companies that are actually presenting their products here at the exhibition. And today, the first innovation session starts in 15 minutes. But after that, we all will head to one of the most magnificent buildings, structures here in Estonia, in Tallinn, to the Seaplay Harbor. And at 8 o'clock, there will be a big reception for all participants. So don't miss that.
And despite that reception, I do hope to see you tomorrow morning here at 9 o'clock when we continue this 3-day conference. And there will be the main event for tomorrow will be the signing of the Digital Health Society Declaration.
So have a good evening and we'll see you tomorrow. But stay at the conference.
Enjoy.